Good afternoon and welcome to this week's Grand Round. It gives me great pleasure to welcome Heather Skelland, who is one of the practice educators in urgent care, who for the demographics of our population, where we do have quite a number of elderly patients, and thinking about falls prevention is clearly part of something that should be everybody's business within the organisation, whatever specialty that you actually work in. And so I'll hand over to Heather. If anybody's got any questions, if you just put it in the chat box or ask them if you're in the room at the end.
Brilliant. So good afternoon, everybody. As Dr. Holden has kindly introduced me there, I'm Heather. I'm one of the clinical educators for medicine and emergency care at the Trust. And I've just been asked today to do a quick presentation about how we've redesigned our falls prevention training and also how we can look at assessing and preventing falls in our hospitals at Southport and Ormskirk. So I'm going to have a quick look at defining what a fall is according to our NICE, because as with a lot of our clinical guidelines, NICE govern how we should do that with a good evidence base behind it. Need to have a knowledge of falls within our trust. Is it an issue? Is it not? And as Dr. Holden kindly said there, our population does lend itself to falls. Have a look at the number of reasons why people do fall in hospital, the tools that we provide to assess that patient's risk of falls, and looking, identifying and discussing those falls prevention interventions that we do actually have in place, as well as what we should do when a patient falls. And this training was born out of the fact that up to the end of last year, the Royal College of Physicians had a training package that was hosted on ESR. And that unfortunately hasn't been updated and technology's developed and we weren't able to access it. So when I came into role in April of this year, one of the first things that I needed to do, Meg Langley gave me the target of, was redesigning falls prevention training so that our nursing and medical staff could access it and complete it, so we can show objectively we're meeting those NICE guidelines and we're doing the right thing to keep our patients safe. So what we did, looked at wherever you start with anything, looked at what guidance there is out there, what is already existing, and also what are other trusts doing, and what we have in place already at Southport and Ormskirk. From there, we designed a PowerPoint presentation, and that was initially thought of would go round and deliver that, but that's quite person intensive and time consuming, and also you only hit the staff that you're going to get. You're never going to get that time for staff to learn if they're going to be worrying about IVs that they need to do or other jobs or unwell patients. That isn't going to be their priority learning when they're on a shift. So we came up with the idea of hosting the training on the intranet as a page, and that has evolved into a falls prevention resource page, and that's searchable on the intranet under falls prevention, and then a quiz at the end to confirm all that learning. So far we've had nearly 400 staff attempt that quiz and pass, so it's really good since we launched it about 2 months ago. We're looking at what is a fall, and the definition from NICE is quite a wordy, but it's an unintentional and unexpected loss of balance resulting in coming to rest on the floor, the ground, or an object that is below knee level. So if a patient falls onto a bed, just because that bed is above knee level doesn't mean they've not had a fall if they've fallen from a height. Hopefully not, but it may be that they've fallen from a chair onto the floor or the ground. Why is this important, really? It is really important, and we'll go on to look at why. The falls and falls-related injuries are really common and serious problem for our older people. And our people that are aged 65 plus have that highest risk of falling. And the impact that we'll go on to look at in a bit is what impact that has on those people. So 77% of people who fell in hospital were aged 65 plus, despite them only being the population of about 40%. Now in Southport and Ormskirk, that is a higher figure. so we can just duplicate that, but more, 77% is probably greater as well within our trust. And then 50% of people that are older than 80 are falling at least once a year. And that's not even on people reporting it. Age UK did a research paper about 8 years ago now about the impact of falling and if people actually reported the falls, and up to 25% said they didn't report the fall because they accepted it as part of ageing, which isn't right. But crucially as well, falls are estimated to cost the NHS more than £2.3 billion per year. So that's a huge part of our budget. Now, we're not going to stop everybody falling, but we should try to stop as much and as the harm coming from that as well. So the impact of falling on older people are quite numerous. We'd be looking at, can cause quite a lot of distress, pain, your injury. So we're looking at when we're reviewing in governance, the more serious falls leading to fractured hips, fractured wrists. Recently had a patient that had a head injury and sadly passed away. So those are our big falls that we hear about, but there's many, for one of those falls with serious injury that's needing further treatment and care or even surgery, there's many more no harm falls as well. And that will impact all those things on our people, on our patients. So that loss of confidence, 21% in that Age UK survey said that they lost confidence after fall, and that's increasing with their age as well. Loss of confidence also directly links to their physical impact, as 62% of them sustained injuries. And if you lose your confidence in moving around, you lose that mobility. We get the deconditioning that we've seen a lot with our older population. That means they lose their independence. And that is a downward spiral for our older people, and loss of quality of life is crucial in those older stages of life, isn't it? You know, the mortality and morbidity increases. And if you start losing your independence because of a fall earlier than you would have done, that's a real shame for your family, your friends and yourself. But it also crucially leads on to mental health issues, loneliness and isolation, which is something we've seen really the cumulative effects of that during COVID much more than we have done before. It's come to much more of a forefront. But falls can also increase that, because if you're not confident in going out to the shops, not confident in moving around the house, that social circle and that circle of life becomes a lot smaller and just exacerbates and builds. For us as inpatients, we're looking at increased length of stay, which is something we all try and avoid. We know the pressures on our hospitals. So if there's something we can do to prevent patients staying in hospital for longer, we should be doing it, shouldn't we? None of us want to cause harm to our patients. And then looking at premature care home admissions. Someone falls, they get deconditioned, they're not moving around as much because of that lack of confidence. They then start being unable to look after themselves, start needing support. That's when you start looking at care home admissions, and social care is our next big pressure, isn't it? Getting people out, packages of care, placement are one of our big delays in discharge to patients. So falls at Southport and Ormskirk, and these are figures for when I wrote the presentation in a very quick level summary for medicine and emergency care. So January to April 2021, and our total falls were 216 in that 4-month period. So that's on average more than one a day, 54 a month. So it's 1.5 falls a day. We can't cut the patient in half. So some days we may have 3, some days we may only have 1. We didn't look any further for the purposes of this into time of day causes along those routes, but a lot of our falls are at night time. That's because it's dark, patients get disorientated, lower staff numbers, etc. So the biggest number of falls are rehab ward, which is is great because it means they're getting them up and getting them moving, but that also sadly increases the falls risk if they're not being supported enough. 11B, which is our gastroenterology ward, and 14B, respiratory. And there's a number of reasons that we can probably all think of for why those wards do have a larger number of falls than others, because of the medical conditions and the nature of the wards as well, and sometimes our environment. So we'll have a look at that later on. And as I said, recently we've sadly had falls which caused a subarachnoid hemorrhage, and the patient passed away afterwards as a result of that subarachnoid hemorrhage. Fractured hip, who successfully had surgery thanks to our trauma and orthopaedics colleagues and was discharged home, and a fractured wrist, which again was put in plaster and fixed. But that can all cause extra stay, extra rehab, extra pain and distress for the patient, the family, the carers, the friends, for something that could be seen as preventable. So going on to that, why do people fall in hospital? And there are so many reasons why people can fall, and they can be broken down into these three categories, and that's the intrinsic ones. So the internal ones, the ones that belong to the patient. Extrinsics are our environment, and hospital is a false environment, it's not home. We have, in some ways, things that we don't have at home, carpets, pets, but we have other things that make it more likely that they fall. And then behavioural as well. So our intrinsic risk factors, a huge one, is have they had a previous fall? And when we go on to look about risk assessment and care planning, what previous risk is, have they had a previous fall? That makes them a risk. And that's because those things, they make the patient nervous, they lose that lack of confidence, causing further falls. I'm sure we've all looked after those patients that are very nervous and very anxious about moving because it hurts, it's sore, they've had a fall and they don't want to. And you can see that cycle of fatal accomplishment, really, that because they're so anxious and so nervous, they're going to fall because they're so worried about it. So an impaired balance, if they've got an impaired balance for any medical or physical reason, the restricted mobility absolutely increases those risk factors. Someone's got a weakness to one side or the other, that is going to restrict them, isn't it? And then our medical conditions, particularly neurological conditions such as Parkinson's, stroke, arthritis, cardiac arrhythmias. Medication, those of you medics that we need to do a medication review to make sure that we're not got medications that are causing falls or are working too well, that say the blood pressure is too low because they've had a lifestyle change and now they actually no longer need that antihypertensive or that sedation. Dizziness is a huge thing for our older population, and there's medications we can add in as much as we can take away for that. Postural hypertension, so as they stand up, the blood pressure goes through the floor, and so does the patient, unfortunately. And again, we've got medication, and our wonderful therapy colleagues have a number of exercises and techniques for advising our patients how they can avoid that blood pressure drop on standing. But to do that, we need to identify the risk is there in the first place. Reduced muscle strength and deconditioning that we've seen so much in the last 18 months with our fit and well patients. They can, if they're so acutely unwell with intensive care or on our high dependency areas, they've got that deconditioning already there. So you may have a 40-year-old that's normally up and working a physical job. Suddenly you think, oh, he's not a falls risk, but he could be if he's been really unwell with COVID for a number of weeks, vented and recovering, because you've got that deconditioning in not using arms and legs and your core. Any foot problems, particularly our diabetics, if they're not aware of them, they haven't got that feeling in them. Incontinence, for that urge, rush to go to the toilet, embarrassment that they need to change and get there and they don't want people to see. Cognitive impairment for a large number of our population with dementia, delirium or any other disturbance of the mind or brain. Any poor vision, particularly at night time. Low mood can also cause, specific to the patient, risk factor for falls as well. If they don't want to get up, but then they've got to, they're not going to want to move. And pain, probably one of the larger reasons, but it's there. So your environmental risk factors or extrinsic risk factors, got a number of them there, and some of them apply to us in hospital and some of them less so. So you've got stairs and steps. We do have them eliminated. We'll say we'll see someone struggling on the stairs in the hospital corridor. There's a lift over there, let's use that. Cut out that risk and support them. But then our therapy colleagues need to also assess that for discharge, don't they? So, frequently when we're going around the hospital site, we will see therapists with their signs on saying, stairs assessment in progress, please use another stairway. And that's in the case of making sure our patients are safe on going home. Clutter and trip hazards, we have lots of these in hospital. And it's our natural environment in hospital, isn't it? It's, we're very used to beds, wires, chairs, tables, curtains, plastic sheets in between each bed, but they are massive risk trip hazards for our patients. If you have slightly fuzzy vision, you don't quite understand the world you're in because you've got a cognitive impairment, and you go to lose your balance and you put your hand out for something that looks solid, a clear screen, and that moves, that's going to cause you, why is that world moving? Something that should look solid isn't solid. If someone's left the brakes off the bed, really easy things that we forget easily day to day going to see our patients really matter in the grand scheme of things. If that was your relative, would you want to have a doctor explain to you, I'm really sorry, your relative fell and they've fractured their hip. They've now got to go for surgery, which we know has increased risk of morbidity and mortality. Well, why did that happen? Oh, someone left the brakes off the bed. It's not right. All of us, when we're with our patients, need to just take that moment, step away from the bed area, make sure the patient's got everything to hand that they need. They're not going to fall out. Bed rails are up if they're assessed as needing them, and that patient is safe. We've all got that responsibility. Floor coverings, we're really lucky in hospital. Our estates team and our health and safety team are amazing. If we report we've got a loose floor covering, it gets repaired, doesn't it? Because it's really crucial. But we've got to report it. There's no point walking over that same point if you know it's there. Your patient doesn't know it's there on the ward. Doesn't matter if it gets reported 10 times before it gets fixed, as long as everybody reports it and it will get fixed. Poor lighting. Nighttime, as I said, falls at nighttime are higher. Naturally, patients get a little bit more disorientated, there's less staff. And of course, we switch the lights off at night because we want them to get some sleep. Sleep heals. But we need to be aware of the patient that may try and get up independently to go to the bathroom, may lose their footing. Glare and shadows are another thing, and our dementia and delirium team can explain this a lot more than myself, but a glare or a shadow to someone with a cognitive impairment can look completely different to someone that hasn't. So a glare may look like a puddle of water, a shadow could look like a person, and that could cause their behaviour to change for something that we can't see, leading to a fall. Low furniture, we've probably again all seen those patients that we've got them out in the chair, we're doing really well, brilliant, they've sat out, come to get them out of that chair and back into bed, they're a bit more fatigued, they're a bit more tired, and the chair's really low, and suddenly we have to start using handling aids to get that patient up. Impact on the patient, mental well-being, suddenly, oh, I got out of bed myself today, I'm feeling really better, oh, but the staff had to use a stand aid or a turner or hoist to get me back into bed. So all that great rehab that we're starting is unfortunately just taken out by the fact we've had to use a device because we've got a low chair. And also, if that patient is able to mobilise independently, but is put in a too low chair, we could be stopping that as well. So always make sure your chairs are right. It's easier said than done. We're always changing around chairs and nursing staff and therapy staff in particular to make sure the right furniture is for the right patient. No access to a phone or call system. So if they haven't got their call bell to hand, how many times you go to do a procedure for a patient, put a cannula in, take bloods, one of the first things you do is move their table out of the way or move the call bell out of the way so you don't lean on it. Please, please, please put it back when you've finished. It's again, taking that step away, saying to your patient, right, if you've got everything you need, you've got everything to hand, and in that time, having a look, if they've got the call bell, if they've got their personal belongings to hand, whether in the bed or in their chair. Poor heating, and that can be hot or cold. I know there's a number of times I've stepped back, I thought, I've done a brilliant job. Our patient's looking really good. They're sat out in the chair, they're looking out the window, and then the sun moves. And the next thing you look, that poor patient is sweating because the sun's moved on and it's glaring them in their eyes and they're sliding out the chair, trying to avoid the sun. Yeah, so it's being wary or sitting them. I once had a patient getting a burn off a radiator because he got himself sat out in the chair, which was brilliant, but he'd had his arm on the chair, which was next to a radiator, and got a small burn off that radiator. Thresholds and doors, less of a problem for us than at home, but still an issue, especially on Wednesday at 1 o'clock when the fire alarm goes off. If you're walking down the corridor and the doors automatically release on you, it can make you jump. Imagine if you're a bit unsure about your balance and your movement, and then that door comes towards you. And we know 1 o'clock on a Wednesday, fire alarm day, our patients don't. And then inappropriate walking aids. So are they struggling with a stick when actually they need a Zimmer? Are they using a Zimmer when they don't even need a Zimmer? Can work both ways. And making sure you do that bedside check as you step away from them. Is that walking aid within reach for that patient? And that's really hard sometimes when you've got a bed, a chair, a table, a drip stand, a pump and a plug. But it's making sure that they can reach it enough that they can shuffle down the bed to get that walking aid to go to the bathroom, if that's appropriate for them. And we've got pets on there. Pets, less of a problem in hospital, but certainly something that our OTs and physios consider during their environmental assessments and home assessments. My own gran broke her neck of femur by falling over her dog. And thankfully trauma orthopaedics repaired it, but the dog was the cause of the fall. The dog was fine. So. And then, as we know, we've got a number of behavioural risk factors that can affect our patients as well. So we've talked about that limited activity and exercise, reducing their ability to move. Poor nutrition and fluid intake. If you're dry, you're dehydrated, that risk of postural hypertension increases. And if you haven't got the nutrition, you haven't got the strength to use those muscle groups and get moving. So it's back down to our real fundamentals of care, making sure a patient is eating and drinking, well hydrated, got good nutrition on board. And if they're struggling, making sure they've got good mouth care and referrals to the appropriate MDTs if needed. And we've all got a part to take in that. Our alcohol intake, if we go and visit ED on a Sunday or even most days of the night, alcohol intake and falls risk, our ED colleagues will absolutely tell us they are big risk factors. And then carrying or reaching or bending. So if your patient is insisting on carrying their wash bag, their towel, their change of clothing while pushing a Zimmer, that's increasing their risk factors, isn't it? So it's breaking down those tasks. or giving them a basket so they can carry things all in one, or us staff supporting them, carrying the items through to the bathroom and coming back for the patient. Number of our falls understandably happen when patients bend over to pick things up, and that also encompasses those with cognitive impairment. They may be bending down to pick something up that we can't see. They can see it, but we can't see it, and they'll be picking something up that they think is there. And because they're going to pick something up that's not there, they haven't got that tactile feel when they don't feel it, and that can cause the fall and that unsteadiness. And then our risk-taking behaviours, climbing on chairs. We've all probably done it along the lines of, oh, I'll just quickly look at that bulb, climbed on a chair and wobbled. If you haven't got such good balance, you've got those things. And a number of our older people are fiercely independent, and they'll want to still do those things like changing a light bulb, altering a light direction. You know, it's about educating them about actually the impact of this could be. And finally, inappropriate footwear is another large one for us. So our red socks or yellow socks for falls risk, if they haven't got appropriate footwear. Getting the family members to bring appropriate footwear in, so not the sliders, not the slippers that slip on, but really good grip, outdoor shoes, brilliant, as long as we can get them over socks. If they've bought socks in, the feet haven't swollen too much, because they've got good grip and it will reduce that risk of fall. And then actually getting the patient to wear them as well. So where does all this come from? And I talked about it, the NICE clinical guideline, number 161, the falls in older people, assessing the risk and also prevention. And NICE have also issued their quality standards as well for the falls in older people. And that recommends that every patient has a multifactorial risk assessment completed, and that those interventions are put in place to prevent an inpatient that is at risk of falling. These should be done within 24 hours of that patient coming into hospital, and ideally as soon as possible. So how do we do that in South Bolton-on-Skirk? So multifactorial risk assessment should be completed to identify that person's risk factors of falling. And we should complete it as soon as possible, because there's no point us thinking, oh, they've only been in 23 hours, I'll get that done, if they're going a really high falls risk and we've not assessed them and put those plans in place. So it's starting to look at those factors that determine a patient's falls risk in hospital. And we talked about if they've had a fall within, we know that includes a risk assessment, and then looking at those behavioural, intrinsic and extrinsic factors. So this is a screenshot from our nursing risk assessment bundle, and there's also a similar one within the ED risk assessment. So are they aged over 65, or are they under 65 and due a risk of falls due to an underlying condition? Those are the key ones that NICE implements. So it's all about not risk assessment, but prevention, identifying those risks and doing something about it. Have they come in for a fall, or have they fallen since admission? And have they fallen in the last 6 or 12 months? Are they worried about falling? So these are the questions that you're going to be asking as you're doing your general admission. Have they ever had a collapse with a loss of consciousness? So that's looking at postural hypotension. Do they have a deficit in balance, the strength or gait? Your doctors quite frequently on assessment will do a neuro exam. That will give you some of those answers. Do they have dizziness? Do they have problems managing their continence? Have they had any nighttime falls or falls out of bed, particularly for those bed-bound patients? And are they confused or have cognitive impairment? And do they have a history of alcohol consumption? So you can see there, those are generally our risk factors for assessing our patients. And it's all very well assessing them and saying, oh yes, right, okay, they are over 65, they do have a cognitive impairment, and yeah, they are dizzy when standing up. It's what we do about it after that's crucial, making sure that we actually put those plans in place. So completing the bed rails bundle and the enhanced level of care assessment should be done for all patients, whether that is just a tick of actually they need just general care, they don't need bed rails, they do need bed rails. And then we've got our falls care bundle, which is the care plan, and that looks at further needs. So if your patient is assessed as at risk of falls, this care plan should be into the nursing notes, and it starts to suggest what other interventions need doing. So you can see on there a falls leaflet provided. There's an easy read, large print one on the intranet for patients that may need a bit easier to read, and has pictures in to help. And it starts looking at that immediate assessment stage as well. What support do they need to help them? Do they need the bed rails down? Because actually bed rails up may cause them to climb over and fall further. Do they need a low bed? Do they need a falls alarm? Do they need moving nearer to the bathroom? All those sorts of things. Full medication review, we have our older person's pharmacist based on FES, who will happily go through all of those details that you need to consider. We're looking at also redesigning some stickers that have been trialled to help us document that that review has happened. So, Bob Batman, he is a training case study, and this is what the nursing staff have been asked to look at during their training. So they'll be asked to admit him, and he's 60 and previously suffered a stroke. He uses a stick to mobilise around home, and he fell at home, which is why he's come into hospital. He's previously fallen 3 months ago and is worried about this. So you can see there, Bob has a number of falls risks identified there. When he stands up, he feels dizzy, and being the diligent person you are doing his risk assessments and admissions, you've done a lying and standing blood pressure, and he has a deficit there of 130/80 and 106/56. So you can see from Bob, he has a number of those risks for falls there. So we would be looking at commencing the falls bundle and also bed rails bundle if needed, and enhanced level of care. On vitals, I've just put a couple of screenshots in there, and you may have seen these when you're doing your ward rounds and looking at your patients. The lying and standing blood pressure assessment is due, overdue or breached. And that's built into the blood pressure assessment. So when the nursing staff complete a blood pressure, can put in whether they need to do a lying and standing, it will do it at the end, and then gives you that risk factor there. So if the nursing staff have done a lying and standing blood pressure assessment and it drops the systolic by 20 milligram mercury or more relative to the lying reading, or below 90 millimeters of mercury, then that symbol appears against the patient screen to say that they're falls risk, they are a falls risk. So it's that extra pictorial representation that this patient that you're reviewing has got a falls risk there. And that's the flow chart for vitals. So it's the increased risk of falls and the lying and standing blood pressure. So when we admit the patient to our area, we should be doing a lying and standing blood pressure on them if we identify they are a falls risk, and that's part of the falls care bundle. So we've identified the risk, we've looked at why people can fall and why it's such an issue. So how can we prevent those falls in our hospitals? Said, identify the risk. Put in place that falls bundle. And that falls bundle, I sometimes think, oh, put in a care plan and it will stop that person falling. It will only stop that person falling if we follow those recommendations on that care plan. And that's for all of the team looking after the patient, not just the nursing staff or the therapy staff. It's everybody. Bed rails risk assessment, as we said, some patients need them, some don't. They've got to be relevant to them. Our enhanced care assessment and plan and following it. We've got yellow wristbands, yellow socks, and then bay tagging as well. So quite often you'll find a HCA that is on a ward and they're sitting within that bay because those patients have identified as being a high falls risk, or they're needing support because they've got cognitive impairment. And quite often a number of those patients are in there at the same time. And our other thing is our low beds, which can be ordered from First Call Mobility. Every ward in their offices has a yellow sign. It's yellow and red, and we can ring up and order a low bed. But please make sure that when that bed is finished, you ring up and cancel that order so we don't get charged, and also they can come and collect it. Bay tagging as well. We're looking at, Matron Helen Hurst is looking at getting some yellow tabards so that when there are staff in there doing bay tagging, it's really clear that those staff are in there doing a job and a role, which means they can't come out of that bay, identifies them as this is their role. So you can't go and ask them, oh, that patient needs the commode, because they are in that ward doing that job. Get crash mats that arrive with our low beds, falls alarms in place, and if you're not sure about how the falls alarms work, the frailty practitioners Terry and Caroline and David can provide you with extra training on that. We are looking at getting some more parts for the falls alarms because there are little bits missing on them, but most wards have them functioning and working. The falls alarms can either clip onto the patient, or we can have a mat on the bed and chair. So as soon as the patient goes to stand up from that chair, it goes off, so you can go and support them, because the patient may not remember. We've told them to wait for a member of staff, or they've rung the bell, they really need the toilet and they've forgotten. So that falls alarm just gives us that chance to go and get there. Only as good as the staff responding to them. And again, it's everybody's responsibility. Patient information leaflet, the patient is at the centre of all this. They need to understand that they are at risk of falls and what they can do to prevent that as well, and to look after themselves. And during the training for the nursing staff, I've also put in a question for the end of, have you got any ideas on how we can reduce falls in our hospitals? The answers that I've got back are the ones that you'd normally expect: more staff, more enhanced care, more time to do our job. And that's a symptom of the health service we're all working in at the moment. But there have been some really good ideas that we might look at getting involved with soon. So in case you haven't seen it, this is our enhanced level of care assessment. Grading our patients on an individual basis. So the mild, moderate, severe, is their behaviour really severe that they need constant one-to-one, one staff member to one patient supervision? Or could it be that actually they've just got eyes on them all the time, but it's not overt, because actually rarely they try and get up without needing that support? Or they might just need to be at arm's length. And again, you can see there the bed rails assessment uses a very similar grid, looking at how mobile that patient is and what sort of mental state they have. So are they confused, disorientated, are they drowsy, are they orientated and alert, or are they unconscious? So working out, if the patient's immobile and they're orientated and alert, they can be used safely if they want. But if they're very confused, disorientated, and they can need support to mobilise, then bed rails are not recommended, because actually they'd increase the risk of that fall if they're disorientated trying to climb over them. So our process for when somebody has a fall, unfortunately, it's something that we just don't want to happen to any of our patients. But the initial thing is, check our patient, check them for injuries. Crucial things: did they bang their head? Did they lose consciousness? Have they got any hip, back, neck pain at all? And those are things that we're going to be looking for initially before we even start moving them. Full set of vital observations, and if they've banged the head, a neurological set of observations as well, and that's all done within vitals on the iPads. Medical team for review. If that patient's got hip, neck or back pain and it's during the daytime, we'd be saying, medics, you need to review them before we move them. If it's nighttime or there's going to be a delay in getting the on-call soon, we'll go through how you can move that patient safely until they get that assessment. And then the inpatient post-fall assessment form, and that goes through what processes need to be done, what needs to be assessed to support you with your decision making. And crucially, after all that, reassess and update that falls bundle and implement any changes that the falls care bundle suggests. And the thing that I always remember as a nurse coming on early morning, handover, 7 o'clock in the morning, the stomach feeling going through of, oh, so-and-so's had a fall today, overnight, they've got no injuries, they're okay. But then I've got to unfortunately then ring that patient's next of kin and inform them that unfortunately they've had a fall overnight. We'll do everything we can, but unfortunately they've got no injuries. And at the moment, we can't wait for relatives to come in and do that face-to-face if they've had a serious outcome from that. And then ultimately completion of the DATIX form. And DATIX is so important because it gives us our patient data for falls and what we can do to target training and improve care, but also it records that patient harm if that has happened. So I talked about how we can get patients up off the floor, and in days gone by, and I remember doing moving and handling training, this trust and other trusts, you got the hoist and you tried to lever in the hoist around the patient, around the pillows and the blankets that have been put down to protect them all. But that never really made sense for me if we were suspecting they'd hurt their hip or they've got back and neck pain, because you don't want to move someone that's potentially got those injuries into a hoist because they're cramped up, you can't keep them straight. And it was used to be, well, 6 people pick them up and put them back into bed. We've now got the flow jack in place, and this is a large piece of equipment. It comes on a trolley. It is currently stored on 15B, so it's accessible to all the inpatient wards at Southport and on G ward at Ormskirk. And hoisting someone from a floor is a risky situation anyway, even if they don't have injuries, because that hoist has a centre of gravity and moves and can very easily topple over. And there are cases, not in this trust, in other trusts where that has happened. So if we're expecting hip spinal injury or any instance where the patient can't get themselves up off the floor, we should now be using the flow jack machine. And we're going to be rolling out that training to our staff. We've already started that, but more so that everybody uses the flow jack rather than the hoist. If the patient's on the floor, they're not going to fall any further. It's not the greatest part of dignity to leave them there, but it's better that we get them up off the floor safely. It doesn't need to be a rushed job. It can be done with calmness and time. And that's sometimes what we sometimes forget. So the flow jack comes with a scoop. And so if hip and spinal injury is suspected, we wouldn't want to roll them. We'd want to use the scoop board, and that's covered in the training of how to use a scoop to put them onto the flow jack, and then the flow jack inflates. I've got a couple of videos to share. They don't have any sound on them. Crucially, this is the hover mat, which gets inflated, as you can see, and the nurses are kneeling on the flow jack, and it helps transfer patient. Some of you may have seen these in other trusts. There's a patient moving device in theatre, really good for taking that weight for the larger patient onto the flow jack there, or transferring from one device to another. And then this video is about how it inflates. What it doesn't encompass is the noise, and that's probably why they've not done these videos with audio on, because the inflator that you can see the nurse at the bottom using there is quite noisy. What you can see there, it inflates 4 different cushions, bringing the patient up to bed height. So you've got the nurse at the top supporting the patient, because it does wrap round as the air increases and brings the patient up. So you'd want to provide that care for that patient, reassurance, and remind them that this is fine. I know it's noisy. We're just bringing you up to bed height. And I'd recommend that everybody during the training actually has a go as being the patient, because there's nothing better than knowing how that patient feels to be able to reassure them. Okay, and then you can see there the height of the flow jack is up to the level of the bed. They've reinflated the hover mat that is there, and those red straps really nice and long, so we can use good moving and handling techniques to bring the patient over onto the bed. Okay, so crucial things. Our care plan 53, it's available on the intranet. It needs completing for all patients who've had falls and filed in the notes. Our governance team, particularly medicine emergency care, would love it if you could scan this in and attach it to the Datix as well, because it saves them going through our paper notes. On the back of it, so the front is very much about guidance. Don't move the patient if they've got neck or back pain or any paresthesia. Don't move them, call medical team urgently and coordinate them, or safely transfer them to a bed and chair if that's appropriate and call medical team. And that includes using that flow jack. What happened before the fall, during the fall and after the fall, and then any relevant past medical history. So what are the patient's risk factors? And our medical review is on the back. So those medics that are called to assess a patient following a fall, you've now got a guide to what you should be expected to do. And also those nice guidance indications for CT head if any of those symptoms or signs are placed either with 1 hour or 8 hours. You've got that evidence base there to discuss with radiology about how important that CT head is needed. And in the training for nursing staff, we just covered what to do when a patient falls. I've been that staff nurse that is scared to write the Datix because I'm scared of putting the wrong thing on the Datix. It is better to report it and it can be looked at after. Our governance team will give anyone Datix training that asks for it. And it can crucially be updated and corrected. So if you put the wrong thing on there and you say, actually, no, I've got that wrong, it can be altered. It isn't set in stone. What we really need to know is what were they doing when they fell? Were they going to the toilet? Were they reaching to get something, using the commode? What caused that patient to fall? Was it witnessed? Who by? Was it patient or staff? And you can detail the names on the witness section part of the Datix form as well. What we don't need to see, and again can be altered if you do by mistake, is put the names in description. You can put initials of staff or patients and then detail them after fully, because these they need to be anonymised on the description and interventions section. And then our immediate findings after the fall. Our governance teams have a daily meeting Monday to Friday, and they review all those Datixes that come in that day period. So they need to know, has that patient got any injuries? They follow it up and then see whether we need to report it to our CCG or to Serious Incident Review Group. How serious is that fall? For those falls with no harm and low harm, they get reviewed weekly within medicine and emergency care by a new group that's been set up to see how we can put things in place to prevent those falls. For those of you that need to do falls prevention training, we've got some of these slides on the intranet hosted, and then for confirmation of learning, there is a quiz there that is completed. Staff need to get 16 or over to pass. However, you can complete the quiz as many times as you like in order to do that. They can do it either within the trust or on their own devices as well by scanning the QR code or sending that link to themselves. And then talked about a falls prevention page within the intranet for anything falls prevention. It's become now, and my idea is that it becomes a one-stop resource for things. So we've got the training there, the FlowJack training, where there's some videos there. I'm going to put up some competencies and some in-house filmed videos to make it more relevant. The care plans are accessible, and also the details for first call mobility and the patient information leaflets are on there as well. So if you type in falls to the search the intranet box up there, you'll come up with that page as the first hit. So, summary, we've covered why the refresh of the falls prevention training was needed, what is a fall, the impact of falls on older people, and crucially most of our population at Southport and Ormskirk, the reasons that patients fall, how to assess patients' falls risk, and look at the falls prevention things that we have in place at our trust, and why it's just important to do that end of bed check as you go away from that patient, having done whatever intervention procedure you've done for that patient that day. Step away, turn around, say goodbye to the patient, say thank you very much for letting me look after you, but also do that check for, have they got everything they need? Have they got the table, the phone, the call bell, the drink, the slippers, anything that they need to hand? It is all our jobs to do that for our patients. And then complete the required interventions for when a patient falls. And those are just some of the references. Thank you very much. Have we got any questions, Dr. Holden? I've got no audio, I'm sorry. You're muted.
Thank you for that interesting presentation, Heather. There's no questions at the moment in the chat box. I did have one, but in fact you answered it. I was going to ask, was the inpatient assessment form a multidisciplinary piece of paper, which obviously you've highlighted it is, so that when medical staff have reviewed a patient, if they've fallen, rather than just writing on a continuation sheet in the notes, they should be actually writing it on the falls assessment form. The other question I also had was, which staff are clinically trained to use the FlowJack if you needed to use it when a patient's fallen?
So we're going to be focusing on our nurses and healthcare assistants and therapy staff as well, but medics by all means are very, very welcome to come and grab me, and we'll do some training on that as well. So anyone that deals with patients, happily come and have training on the FlowJack.
And do we have a hover mattress as well as the FlowJack?
Yeah, it's within the FlowJack itself.
So if I had a patient and they've fallen, how do I get the FlowJack and the hover mattress?
You can put a call, a porter's job out for them to come and collect it from 15B's therapy room and bring it up, or get a member of staff to go and collect it from 15B.
Thank you. I don't think I've got any other questions. I think it just remains for me to say thank you very much, Heather.
You're welcome.
Thank you for your time, and I'm sure this is a valuable resource that people will be able to use in the future.
Yeah, I hope so.